welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries and Trees section of the ACCP Communities website.
We'll go ahead and get started. Just standard procedure, I nor my mentor have anything to disclose in relation to this presentation today. Some abbreviations that you may encounter throughout the presentation have been included here for your reference. So as they will be made available later, those can be used for reference. All right, so let's go ahead and jump into the background. To start, we'll talk about the use of thrombolytics in acute ischemic stroke. In the event of an ischemic stroke, we know that blood flow in the brain is impeded by some sort of occlusion, whether it's thrombotic or cardioembolic in origin, and the goal of management is to restore perfusion quickly, and thrombolytics may be a means of treatment in select patients. We are all most likely familiar with the 2019 American guidelines that recommend appropriate administration parameters for thrombolytics. So ideally, we have patients who present with moderate to severe symptoms within 4.5 hours of onset. They have a blood pressure of less than 185/110. They're not hypoglycemic. And most importantly, they don't have a hemorrhage that's seen on a non-con CT. However, the administration of thrombolytics does not come without risk, as we're familiar. These agents do facilitate degradation of blood clots. So any evidence of current major bleeding or recent history of bleeds within specific time frames would lead us to not proceed with thrombolysis. Outside of bleeding or trauma events, other contraindications for thrombolytics revolve around the patient's anticoagulation status at baseline. So we know that warfarin is not an absolute contraindication, but we do need an INR of less than 1.7 to allow for thrombolytic administration. The use of anticoagulants such as direct thrombin inhibitors and our NOACs, such as apixaban, deny the use of thrombolytics unless those agents have not been used in at least 48 hours prior to presentation. Something that's important to note is this contraindication was made based on expert opinion only, out of concern for risk of bleeding events. Being anticoagulated at baseline and adding a thrombolytic that further potentiates anticoagulation offers a reasonable theoretical concern, but these risks have not been clearly established in literature. Now we're going to quickly refresh on our NOACs and our thrombolytics. Our factor Xa inhibitors specifically inhibit the effects of factor Xa from converting prothrombin to thrombin, thereby preventing clot formation. And then our dabigatran is our direct thrombin inhibitor, and it inhibits the formation of clots a little farther down the coagulation cascade by directly binding thrombin. These agents are prescribed to patients to induce a state of anticoagulation, whether that be for atrial fibrillation, stroke prophylaxis, or VTE treatment or VTE prophylaxis. Now we transition over to the thrombolytics. Alteplase and tenecteplase are generally used as the lytic agents of choice. In brief, they do function as a tissue plasminogen activator, meaning that they binds plasmin, prompts its conversion to plasminogen, and facilitates fibrin degradation and subsequently clot lysis. But a question to think about is, what about our patients who've been on anticoagulants, they're adherent to their medications, and they still develop a stroke despite anticoagulant use? Maybe, we're withholding medications in a population that could potentially have a lot of benefit from thrombolytics. So what do we know or not know, for that matter, about thrombolytic use in patients with a history of NOAC use? Starting with NINS, this landmark trial established the efficacy of Alteplase in improvement of functional outcomes in patients who presented with an acute ischemic stroke within 3 hours, and notably patients who had taken anticoagulants or antithrombotics within 48 hours preceding stroke symptoms were excluded. Another landmark trial includes the ECAS-3 trial, which established the safety of Alteplase in patients up to 4.5 hours after their presentation. In this double-blind randomized placebo-controlled trial, Alteplase administration in patients within 4.5 hours of symptom onset was associated with a more favorable disability outcome at 90 days compared to the placebo. But again, patients who were on anticoagulants at the time of the presentation were excluded from the study. Now, we're going to shift gears a little bit and we're transition to some literature that describes the outcomes of patients who did get a lytic and while they were on anticoagulants. So we move into a 2022 article that was aimed to describe the risk of intracranial hemorrhage in that particular patient population. Acknowledging that the administration of thrombolytics is technically a protocol violation, information for this retrospective cohort study was obtained from the Get With The Guidelines, Stroke, and ARMS registries. Ultimately, this evaluation concluded that adjusted risk of symptomatic intracranial hemorrhage was not significantly higher in patients who were treated with Alteplase and received NOACs in the previous 7 days. It is worth highlighting, though, that 7-day time frame doesn't correlate with our current guideline recommendations of 48 hours. So those outcomes may actually be different whenever we compare apples to apples. And then lastly, our last piece of literature before diving into today's article is a similar multi-center retrospective cohort study that was published in JAMA of last year, or JAMA Neurology last year. So in this retrospective evaluation, investigators conducted a literature search for reports on thrombolytic administration for patients taking NOACs, and they gathered information from the published reports as well as direct contact from those reporting groups. Similar to the previous study, the primary outcome was symptomatic intracranial hemorrhage within 36 hours of that thrombolytic administration, and the investigators ultimately concluded that based on adjustment for stroke severity, NOAC use was not significantly associated with an increased risk of harm or with the receipt of thrombolytics. So at this time, we'll proceed into our discussion of today's article on the risk of bleeding following non-vitamin K antagonist oral anticoagulant use in patients with acute ischemic stroke treated with Alteplase, which was published in JAMA Internal Medicine of January of this year. This article essentially consisted of two studies. It was a retrospective cohort study and later a meta-analysis to incorporate findings of the former evaluation into current evidence on NOAC exposures and in patients treated with Alteplase for acute ischemic stroke. So first, we're going to start with the retrospective cohort study. As the article title implies, the authors aim to evaluate the risk of bleeding in patients who had received Alteplase for acute ischemic stroke and had recent exposures to NOACs. While there is some evidence that does exist on this topic, as I had highlighted in the background section, the investigators of the study aim to expand the available literature to include a more robust Asian representation, as previous studies had limited representation by those communities. This was a retrospective cohort study that was conducted completely in the country of Taiwan between January 2011 and November 2020. Data was obtained completely through the claims-based data, utilizing Taiwan's National Health Insurance Research Database, which that is a database that contains all data for all medical claims covered by their national health insurance program. Something that's also notable about that is that insurance program does cover nearly 99% of that nation's population. The evaluation consisted of a fairly broad inclusion criteria. At least 20 years of age, they were treated with Alteplase in the emergency department for an acute ischemic stroke. But patients were excluded if they had received multiple types of anticoagulants, had received anticoagulants other than NOACs or warfarin, so say low molecular weight heparin, or if the patient had received adairacizumab prior to Alteplase treatment. Patients who were included in the evaluation were separated into three groups based on their anticoagulant exposure, namely the NOAC group, which it consisted of dabigatran, rivaroxaban, apixaban, and edoxaban. And then other groups consisted of those exposed to either warfarin or no anticoagulant at all. Particularly pertinent to highlight that anticoagulant exposures were determined through prescription claims data. So prescriptions for either NOACs or warfarin within 2 days prior to the index date counted as positive exposure. Because the data was obtained through medical claims, well, in that case, true anticoagulation status cannot be ascertained for those respective patients. The primary outcome of interest was the development of intracranial hemorrhage following the administration of Alteplase. And other outcomes evaluated were all major bleeding events during the index hospitalization. So this did include gastrointestinal bleeding and bleeding in other sites, specifically, say, intraorbital or retroperitoneal bleeds, for example. Those outcomes were identified through ICD-9 and ICD-10 10 codes. And mortality is also of interest, and this information was gathered through Taiwan's National Registries of Death. Moving into the statistical analyses, propensity score matching was performed to best align comparator groups for evaluation and the minimization of confounders. Differences between baseline characteristics were evaluated with the standard mean difference, and then absolute risk difference and odds ratios were calculated for each outcome and were evaluated utilizing a 95% confidence interval. Some additional statistical investigations included sensitivity analyses on the effect of atrial fibrillation diagnosis or the timing of the anticoagulant prescription prior to the index date. So here's a depiction of the patient selection or patient group allocation process. 7,512 patients who received Alteplase during the index time period for acute ischemic stroke were screened, and after application of the exclusion criteria and propensity score matching, there were a total of 455 patients that were evaluated in the NOAC versus non-OAC or no NOAC group based on a 1-to-4 propensity score matching scheme. I've also included the distribution here to the right for the warfarin versus the NOAC comparison, but in the interest of time, our focus during today's discussion is going to be completely on the NOACs versus the non-OAC exposures. Here we have the baseline demographics of patients included in the NOAC versus the non-OAC group before and after propensity score matching. After propensity score matching, the standard mean difference between groups was less than 0.1, which is considered a negligible difference. Patients were mostly in their 70s, and they had a slightly higher representation of females. The estimated NIHSS score was 14 in both groups. And then again, because all of this information was obtained through claims data, that actual NIHSS score had to be calculated based on a claims-based stroke severity index. Comorbidities that were identified through ICD-9 and 10 codes were also evaluated at baseline. These comorbidities were present similarly across groups, with coronary artery disease and then also heart failure being the most prevalent across those groups. Now, as we move into the outcomes of interest, patients who were taking NOACs prior to Alteplase administration had a 37% increase in odds of developing an intracranial hemorrhage, although it was not statistically significant. And then when looking at the secondary outcomes, there was also no statistically significant difference between the groups for any of those outcomes. Other critical bleeding included those all major bleeding events, excluding instances of intracranial hemorrhage. And then patients who received NOACs were at a 200% increase of risk of developing a bleed in those areas. And it may not have been statistically significant, but it could potentially be clinically significant. Now, although not statistically significant, an interesting finding was that mortality in hospital and within 30 days was actually lower in our patients who had those NOAC exposures. The majority of patients on NOACs had a diagnosis of atrial fibrillation, which could potentially indicate the need for chronic anticoagulation. And when only looking at patients who had a diagnosis of atrial fibrillation, there was no statistical difference between the exposure groups for any of the pre-specified outcomes. Notably, the odds of intracranial hemorrhage and all major bleeding were reduced by 45 and 25% respectively in patients with exposures to NOACs prior to receiving that thrombolytic. And then when evaluating the effect of the timing on that anticoagulant prescription on outcomes, there were also no statistically significant differences in those odds of meeting any of the pre-specified outcomes. Keeping those results in mind, we're going to transition to the meta-analysis of this article. With their newfound results of an Asian population, the investigators aimed to synthesize an updated literature source that would expand patient representation and increase their external validity of findings. To quickly touch on some previously available literature, there was a meta-analysis that was published in Stroke in 2020 that did evaluate the safety of IV thrombolytics in patients taking DOACs. Those outcomes compared between patients taking the NOACs or either warfarin or no anticoagulant. The primary outcome was the rate of the symptomatic intracranial hemorrhage by both the NINS and the ECAS-2 definitions, depending on that original literature source. And then Ultimately, the results of this preliminary meta-analysis showed that NOAC exposures prior to thrombolytic administration was not associated with a significant risk of symptomatic intracranial hemorrhage. Moving into the study design, investigators performed a literature search across several databases, including Cochrane Library, Embase, Medline, and Scopus. And then, just similar to the research question for their own retrospective cohort study, trials were included if they were original studies that evaluated bleeding events in patients who were taking NOACs and were treated with thrombolytics for acute ischemic stroke. Original studies were included in this evaluation, so randomized controlled trials or retrospective cohort studies that is essentially aligned with the PICO questions that are outlined. Case reports and animal data and reviews and opinions were excluded. Similar to the retrospective cohort study, the goal was to evaluate the rate of intracranial hemorrhage, major bleeding, and mortality. However, in the meta-analysis, the investigators specifically looked at intracranial hemorrhage as the primary objective, and then any intracranial hemorrhage in general as one of those secondary outcomes, which those outcomes are also consistent with previous outcomes in the meta-analysis that I previously highlighted. Data was evaluated using a pooled risk difference and odds ratios with 95% confidence intervals. The original literature search yielded 5,836 results, and after application of inclusion-exclusion criteria, 9 studies were included in the meta-analysis. 5 of those studies had already been included in the meta-analysis in the background section that I talked about, and there were 3 additional studies that were identified through the literature search. So the figure here that is extracted from the original article includes comparisons of both the NOACs to both non-OACs and warfarin. The top half of the figure is where we'll direct most of our focus. There were no statistically significant effects of NOAC use on the odds of developing intracranial hemorrhage, major bleeding, or in-hospital mortality. But I would like to point out that the results of the retrospective study presented earlier included any intracranial hemorrhage outcome since the ICD-9-10 codes were utilized for data collection. So the nature of that hemorrhage could not be elucidated from that data. And then whenever we peek over to the right at the forest plot, we can see that the odds of the symptomatic intracranial hemorrhage and in-hospital mortality tend to favor the NOAC group. However, it's not statistically significant. So taking these findings of the cohort study and the meta-analysis into consideration, what did the investigators ultimately conclude? They concluded that this study found no compelling evidence of higher risk of intracranial hemorrhage, major bleeding events, and mortality following Alteplase treatment for acute ischemic stroke in patients receiving NOACs compared to those having not received any anticoagulants. Getting into the evaluation of this trial, its nationwide design strengthened its ability to gather patients for evaluation. Although we didn't dive into the warfarin and NOAC comparison outcomes, the inclusion of warfarin data points helps to put into perspective the risk of bleeding when Alteplase is administered to someone with some form of anticoagulant exposure. As mentioned previously, warfarin use alone is not an absolute contraindication to the use of thrombolytics. So with an INR of up to 1.7, yes, it reflects some degree of anticoagulation. The findings of the lower odds of bleeding outcomes with NOACs are reaffirming with considering the bleeding risk with these thrombolytics. Now, on the flip side, this trial does have a number of limitations that deserve mentioning. The investigators aim to increase the available data on Asian populations. Now, its restriction to only Taiwan may not be representative of all Asian populations or reflect practices and outcomes in all Asian countries. And the information utilized in the retrospective study and later applied in the meta-analysis was obtained through claims data and prescription records. So there's no available information to really assess the clinical parameters that could have been associated with a higher or lower risk of developing intracranial hemorrhage. And then again, because obtaining through ICD-10 codes, we don't have quantitative data that is going to further limit our application of these results. And then lastly, if you recall, the patients were assigned to their respective groups because they had a prescription or lack thereof within the previous 2 days of their index visit. So in that case, that we are not able to really assess if these patients were compliant with their medications, if they had even picked them up. So really knowing that anticoagulation status prior to thrombolytic administration remains a mystery. So ultimately, the results of this study showed that there was no significant increase in the risk of bleeding events with patients on DOACs and who had received Alteplase for an acute ischemic stroke. But based on the available information from this cohort study and the meta-analysis, I don't feel that there's sufficient information available to recommend thrombolytics in those patients who have received NOACs within the previous 48 hours. But if I have a patient who receives a thrombolytic that's found later that they were actually on a NOAC, then at that case, I don't feel that I would be as fraught with worry about potential adverse effects. So maybe it brings a level of comfort. And then lastly, we're not able to identify any characteristics that would increase that risk of intracranial hemorrhage or other major bleeding. I wouldn't rely on the results of this study alone to make inferences on which patients would be at the lowest or highest risk for those complications. So I'd like to extend my gratitude to my residency program director, Liz Lucas, for her valuable guidance on today's presentation. And at this time, I'm going to conclude my presentation and I'm happy to open the floor to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.